Yeah, welcome to EASL Studio, your weekly hepatology broadcast news. In today's episode, we will talk about cholangiocarcinoma and highlighting guidelines and exploring the horizons beyond. So my name is Thomas Berg. I'm a hepatologist from University of Leipzig and also co-producer of the EASL Studio. So why we are talking about cholangiocarcinoma? Perhaps you are aware that we have the Cholangiocarcinoma month in February, and tomorrow there will be the World Cholangiocarcinoma Day. And there's another reason why we want to discuss cholangiocarcinoma. And you know, cholangiocarcinoma comprises several forms or subtypes of tumors depending on their location within the liver or outside the liver. So we have the intrahepatic cholangiocarcinoma, the periheal, the distal, and we also have the gallbladder cancer. And quite often these biliary tract cancers, the cholangiocarcinomas, are discussed together. But for the first time, EASL and ILCA together launched a guideline that was published quite recently, solely dedicated to intrahepatic cholangiocarcinoma. And this is, I think, an interesting approach, and I would like to discuss with a very esteemed panel why it's important to go towards this direction, to have a kind of a segregation of the cholangiocarcinoma types, if you want to say, and what are really the news. And there's a lot of innovation here related to cholangiocarcinoma. So it's really a big pleasure to introduce our panel. And I would like to start with also a panel member of the EASL-ILCA guideline on intrahepatic cholangiocarcinoma. It's Professor Juan Valle from both Manchester as a medical oncologist, but recently appointed Chief Medical Officer of the Cholangiocarcinoma Foundation. So welcome, Juan.
Thank you very much, Thomas. It's a pleasure to be here, particularly ahead of World Cholangiocarcinoma Day.
Yeah, thanks a lot. Then I would like to introduce Professor Robin Kelley. She was also a member of the writing committee of the guideline panel, and she's a medical oncologist from UCSF, and she leads the hepatobiliary clinical trial program for patients with hepatobiliary cancers at UCSF. And she's also well known as a lead author for a recent phase 3 trial giving a new immunotherapy-based systemic treatment for cholangiocarcinoma. So it's great having you here, Katie. Welcome to EASL Studio.
Thank you so much. And it's an honor to be here, especially on World Cholangiocarcinoma Day. Thank you.
Yeah. And in addition, and this is also related to the innovations, we do have a cancer biologist, and it's a big pleasure to introduce Professor Daniela from Mount Sinai in the US. Welcome, Daniela.
Thank you, Thomas, for the introduction, and it's a pleasure to be here with all of you today. Such a esteemed panel. It's a pleasure to be here.
No, it's great, and it's really important, I think, to say there are not so many people that know so much about, let's say, the molecular profiling, the molecular subtypes of cholangiocarcinoma, and you're really dedicated to bring it into clinic, and this is certainly something our audience is very much interested in. And perhaps as a starting question to all of you in the beginning, and Juan, Katie, you were both part of the writing panel of the guideline. Why is the idea so important to have a guideline now dedicated on the specific form of cholangiocarcinoma and not, as ESMO and other did, to bring or to merge all these together?
Yeah, so we have for some time, as you know, pooled together patients with different types of biliary tract cancer. You mentioned in your introduction intrahepatic, perihilar, distal cholangiocarcinoma, as well as gallbladder cancer. And whilst that's appropriate for certain studies, I think as a community, we've become increasingly aware that these are biologically distinct entities. They have different risk factors, they have a different biological behavior, and increasingly they have a different therapeutic algorithm. So it makes a lot of sense now that intrahepatic cholangiocarcinoma, for which there is much more evidence emerging in terms of potential treatments for the future, now stands out as its own entity and warrants specific guidelines.
Yeah, Katie, what do you think?
I completely agree. And I think not only with what Juan said, but I would add also that I think intrahepatic cholangiocarcinoma has a distinct point of care in the community and of oncology as well as hepatology, and that it is often first diagnosed and treated by hepatologists. And so I think it's extremely important that EASL and ILCA team together for this guideline, because while distal cholangiocarcinomas and often perihilar reach us in oncology through the surgical pathway, I think often the intrahepatics end up initially on an HCC path. And it's very important, I think, for hepatologists and oncologists to work together early for this diagnosis. And so for that reason, also, besides the biology, the point of care that these tumors are seen, I think requires a special guideline.
Yeah, I think this is a very interesting point. And in preparation also of this studio session, I also thought about that the algorithm for treatment resemble more hepatocellular carcinoma, more and more, you know, for intrahepatic cholangiocarcinoma. Would you agree on that? We are really moving a bit towards that algorithm that we are using or we were using for hepatocellular carcinoma are now also entering in the field of intrahepatic cholangiocarcinoma?
I guess I'll hazard the first response. I would say in some ways, yes, but in many ways, no, in that we know the biology of multifocal intrahepatic cholangiocarcinoma is very different than the biology of multifocal HCC. And while there's certainly interest in the role of liver-directed therapy for localized intrahepatic cholangiocarcinomas, we definitely need to have a different thought process for multifocal disease. And so I think that it is very important for us to underscore the differences in biology, the importance of molecular diagnostics in cholangiocarcinoma, and the importance of understanding how the biology is very different for multifocal disease in particular. They are not a tumor that we should be doing serial TACEs throughout the liver or serial Y90 treatments, because the biology of multifocal disease is essentially M1.
Okay, that's an important statement. We will come later to the local regional therapies related to also the new data we have, how this tumor can be treated. Anything to add from your side, Juan, or you fully agree with what Katie said?
Yeah, well, I think we can certainly take benefit from the multidisciplinarity of the team involved. And, you know, when there has been a focus on things like local regional therapies and transplantation, you know, Katie's absolutely right. We cannot just transpose the treatments that we use for one type of cancer to another. But we can learn from the approaches. We can learn from the multidisciplinary approach of assessment, stratification, and study. But often, because these are very diverse entities, you know, the way we apply these treatments is going to be different.
Yeah. Well, we discussed that we categorize it according to the location, right? But in the guidelines, there's a big focus also on subtypes, pathological subtypes, and the large duct, the small duct subtype. So Daniela, can you give us any background information why it's important to have this subclassification from a pathological stage or after resection or after biopsy to get these?
Yes, absolutely. So before entering into the proposed macroscopic or histological classification, I would like to echo what has been said, that it's really important to differentiate the different subtypes. The more we learn, the less we know. One thing that is clear is that all the different subtypes are different molecularly, and it's really important now to differentiate not only intrahepatic versus extrahepatic, but also include the distal and the perihilar. That is really important. And again, it's like we don't really know how different they are, but we know that they are different. In terms of what you're mentioning, in terms of classification, the recent proposal is the macroscopic macroscopically, there are 4 subtypes. And while again, I don't have experience from patient care, we do use this classification in our research labs. According to macroscopic classification, we have mass-forming, periductal infiltrating, a combination of mass-forming and periductal infiltrating, and then we have an intraductal growing type. And these are important because it might have important difference in terms also of outcome. And again, I think that here Juan and Katie know more about that, but it's important to know this subtype because, for example, the combined form, mass-forming plus periductal infiltrating as a worse outcome is more likely to have certain type of infiltration of perineural infiltration. But and it's important to consider this, and this is a first level.
Daniela, hang on for a second, perhaps to give a chance also to our audience. So we have on the one hand the pathological classification with the large duct and the small duct, and this is easy for pathologists to differentiate both, right?
Yes, and this is also important to combine with the macroscopic that I was referring to, since a certain small type is more likely to be mass-forming, whereas the combined mass-forming plus periductal is more likely to be large type. And the differentiation that you mentioned between small and large type is also important because although still there are not as strong evidence, we know that the small type is more likely to be associated with targetable alterations like IDH1 mutation and FGFR2 alteration, which we know now they can be targeted with selective inhibitor, and they are recently approved.
And how easy is it, perhaps also to Juan and Katie, to differentiate by imaging whether it's a mass-forming type or a periductal infiltrating, but especially the mixture of both? Can this be differentiated just by imaging?
It can be very challenging. And I think it's often possible to identify a mass-forming cholangiocarcinoma. What is then important to try and define is whether there's an element to periductal infiltration, because if it is a mixed tumor, then it is more likely to be arising from the large ducts and have a more adverse prognosis because of the perineural invasion and the lymphovascular invasion that Daniela mentioned. But it can be very difficult. MRI scans are probably the best ones to be able to delineate that, but even so, it can be difficult.
Yeah, and Katie, in your clinical practice, in your tumor boards, is there a discussion about this is a mass-forming plus periductal infiltration? And do you get the information from your pathologist what subtype you're dealing with?
Well, I guess I would underscore that only a minority of intrahepatic cholangiocarcinomas are resectable and present with a localized tumor that can be assessed in this way. And the majority of patients, unfortunately, are not resectable and have more advanced disease that may be a widespread throughout the liver or very difficult to ascertain what the original tumor was versus a conglomerate versus a satellite lesion. And so I'd say pragmatically, the majority of patients in a medical oncology clinic have more advanced disease, and this is not clinically relevant yet. But going back to what Daniela said earlier, which I completely echo and agree with and think was very wise, is we need to learn more about what these patterns mean biologically, because they are clearly different. When we do catch an early tumor, the mass forming versus periductal infiltrating are different biologically, different genetically, and we just don't fully understand what they mean yet.
And we quite often do not have this information from the clinical trials, right?
The clinical trials are mostly in advanced disease patients where we wouldn't ever have a single discrete mass resected in the majority of patients.
Yeah, Juan, you wanted to comment, yeah?
Yeah, I was just going to say, this is one of those data points at the moment that Katie's right. We don't have an awful lot of experience built into the clinical trials in terms of understanding, the granularity around the biological behavior. But now that we know that these things do behave differently, the mass-forming cholangiocarcinomas are the ones that are more likely to have the targetable alterations, FGFR2, IDH1, then we know that going forward, it is a data point that we need to collect. And in time, we may need to stratify it at clinical trial entry, depending on what the question is for clinical trials. But in terms of understanding what the data is telling us, as Katie has said, we just need to understand much more about the biology of these, what looks like slightly different conditions.
Yeah, I think this is really very important and clearly highlights that we have to take these data, we have to put it into our database and really to learn how it will translate into differential diagnosis and management, treatment, and so on. And I think we can now also move forward towards treatment options. And of course, we want to start with curative treatment. And it's well known that curative treatment is mainly resection. I think that's a given, and everyone would agree. But the question is sometimes resectability. And when I read the guideline, I was a bit surprised. What I'm not saying surprised, but there's a lot of interest to defining whether lymph nodes are involved or not, recommending PET scanning, perhaps even ultrasound, endoscopic ultrasound with a puncture of the lymph nodes. I have to say, in our clinic, it really, if the tumor is resectable, there's minor, let's say, lymph node involvement, maybe, we go for resection, irrespective of whether there might be 1-2 lymph nodes involved. So what is your recommendation here? I think it's not so clearly written in the guideline whether you can go for resection or what the recommendation is if you have the feeling that there might be a lymph node involved. So perhaps Katie first and then Juan.
Yeah, this is an eternally challenging question.
Yeah.
I think we know that lymph node positivity on surgical resection is prognostic. We don't know if it is therapeutic in terms of whether resecting positive lymph nodes will truly improve the outcome. But I agree with your clinical practice, or my group at UCSF also agrees that if a patient is a fit candidate for surgery and has an easily resectable tumor, the surgeon will take the patient to surgery and resect the regional lymph nodes as well. That said, we do carefully try to think about this prognostic import when we deal with a marginal candidate, either because of hepatic reserve, the location of tumor, multifocal tumor, or age and comorbidity. If it's somebody where we honestly are not sure that they're a safe surgical candidate, or if the prognostic factors of the tumor are really too negative, having positive lymph node involvement is a really poor prognostic factor and high likelihood of recurrence. And somebody who's borderline marginal for surgery really probably shouldn't go to surgery if they have positive lymph nodes. At least that would be my stance.
Yeah, no, that's very important. And Juan, do you want to comment or do you agree?
Yeah, I completely agree. And
Okay.
I was just going to comment on the PET scans. So I was involved in some of the one of the reviews looking at the role of PET, and we just need to be very clear what it's telling us. It's not really to define anything around the primary tumor itself. It is about understanding node status, metastatic status, and in patients who have had surgery, identify possible recurrence. So once you understand what the PET is trying to tell you in terms of information, it makes it much easier to apply it. And completely agree with Katie that we would go with patients who either have a high-risk tumor or a high-risk candidate for surgery are the ones where you really want to make sure that you're not subjecting them to, you know, a major resection when the likelihood of a good outcome is poor.
Yeah. And Daniela, how often do you see it if we do a puncture of a lymph node, or let's say a metastasis, or even if it's, how often do you see a different molecular profile at the same moment? It's not, you know, after treatment and you have a recidivism of a tumor, but at the same time when you have a metastasis or lymph node metastasis or distant metastasis, that you find different profiles, and whether this could also guide treatment decisions?
I would love to have the answer to this question. Yes, absolutely. I mean, I can speculate that of course the molecular profile will be different. The same way that it's like, even within one tumor, we know, right, there is a heterogeneity from one area to the other, right? The limitation of biopsies, metastasis. I would love to have access to as much material as possible to conduct all these studies. We are quite limited, you know, when it comes to material, and cholangiocarcinoma in particular. I think we have improved over the years, highlighting and stressing the importance of access, you know, like accessing the tissue, analyzing the tissue, but we're still behind, even just compared to HCC. So again, it's like, I think that everything is going to have a different molecular profile based on what we've seen in other cancer, but I do not know about cholangiocarcinoma. I can just speculate and argue that, you know, we need more tissue.
Good. This
I
is
would add
clear
I
advice
would love
to
to add
the...
just.
Yeah, please, Katie.
Oh, sure. I was just going to add in one of the molecular aberrations that is of great interest right now due to its therapeutic actionability, which are FGFR rearrangements. I think we are coming to appreciate that the root rearrangement, the truncal driver rearrangement or fusion, does seem to be concordant between primary and metastatic sites. But like Daniela said, resistance mutations, particularly in the kinase domain, they often may be pre-existing, but also certainly proliferate under selection pressure of treatment, are heterogeneous between primary and metastasis. So it does seem, at least from my experience, that driver mutations tend to be somewhat truncal or clonal from primary metastasis, but these acquired resistance mutations, or sometimes that are pre-existing, are much more heterogeneous. I don't know if Juan and Daniela agree with that comment.
Yeah, Daniela, you want? Yeah.
Yes, I would like to. I totally agree with you. At least we saw for FGFR and IDH, they tend to be truncal along with KRAS mutation. But also we had few cases where we had one patient that had two different fusions in two different regions. So it's like different partners of FGFR. And again, those are like single cases, and we need a larger cohort to understand that. But I totally agree with you that certain truncal drivers like KRAS, FGFR, and IDH. But again, still, I think we need large studies to fully understand what you were mentioning, the depression, the clonal evolution. We know very little in cholangiocarcinoma about this. There are very few studies we can count on in one hand.
Yeah. So I think you see, and we will come really to this point, because then it comes a bit complicated when we really go to the molecular profiling and how to treat this patient. But you have already realized there's a lot of going on, and you really have to be a specialist really to understand this and what the treatment options will be. I want to come back quite briefly to the curative treatment. And of course, if a patient is resectable, this is written in the guideline, you should go for the resection as the best treatment option. If non-resectable, then if it's a small tumor, and I think we have to highlight that non-resectability means perhaps because liver function is so poor that you, or patient age or whatever, that you can't go for resection, or the tumor is too large, too big to go for resection. But now there are these new data, a bit in line with what I mentioned, treating like HCC, that patient with an intrahepatic cholangiocarcinoma, let's say within the HCC Milan criteria, were treated in a big study from China just with microwave ablation and not with resection, and the results show quite similar 5-year survival. So do you think this is something we should explore further also for those being resectable? Is it going too far? Is it really should be reserved for those being non-resectable for whatever reason? And in the guideline, it's really if it's a small tumor, but here it was within Milan criteria. This is really a bit beyond of what we thought we could do. So Juan, do you want to comment on this trial? So I can give you the 5-year survival rates where nearly 45% in the resection group and 40% in the ablative group.
Yes, yeah. So just to quickly give a little bit of context, the standard of care has developed in terms of systemic treatment and chemotherapy, which included patients with unresectable disease as well as those with metastatic disease. So in general, over the many years, patients have been receiving systemic treatment. But you are right, there is a cohort of patients who do have what appears to be quite localized disease, which is unresectable for various reasons. And given the interest in local regional therapy, a number of different approaches have been used for local therapy. The Chinese study, which was just published in this year, was interesting in that it was a real-world data study performed over a very long period of time, 12.5 years. And what they were able to show that across that time frame, the techniques improved and the outcomes improved. So there's something around, local regional therapies, ablative therapies are not one thing. And even when you think you've got the same modality, it can evolve over time. The second thing to say about that study that struck me is that where the outcomes were the same, it is where you were able to achieve a 5 millimeter margin all the way around, whether it was surgery or with microwave ablation. And if you look at the microwave ablation patients, and there were 221 altogether, 92 patients, which is 42% of the patients, so under half, you were able to get that 5 millimeter clear margin. So I think we just need to be a little bit careful about just saying this is equivalent. You know, in patients where you might achieve a 5 millimeter margin, both surgically and microwave ablation, then the outcomes are comparable. But this is based on retrospective real-world data. It's not being tested in a prospective randomized trial to be able to confirm that.
Yeah, no, I fully agree. And I think what you are telling us is if the patient is resectable, go for resection. But it opens a bit the door and gives a bit more evidence that even if the tumor is a bit smaller, you can really achieve something with local regional therapy. And Katie, in addition, if a patient initially is non-resectable because the tumor is too big or you need the liver remnant that will remain, so you have to introduce regeneration, we quite often use a portal vein embolization before resection, you know, that we have enough liver that the patient can survive. But now more and more data, and I think centers are using sometimes even combination that they add chemotherapy plus the transarterial radioembolization, TARE or THIRD, or how you want to name it. What do you think is the importance of these things as a kind of a downstaging to achieve resectability for our patients?
So our center also is often, but not often, I'd say, considering TARE in selected cases for a radiation segmentectomy type approach where the appeal obviously is that one is treating the tumor and inducing a contralateral future liver remnant hypertrophy in parallel. The portal vein embolization downside obviously is you're not addressing the tumor and compromising vasculature in parallel without getting anti-tumor activity just from the procedure itself per se. So I think that, as always, with so many things with cholangiocarcinoma, patient selection is paramount, and that we like to consider this type of approach in a patient where we suspect that their tumor is not proliferating rapidly and is behaving biologically as a intrahepatic localized tumor without nodal involvement and without rapid. And so patients who have extensive multifocal disease would give me pause in doing this because it requires time and it requires the whole point of it is to do local therapy. And if a patient metastasizes, all is lost. So, or not all is lost, but it's been not effective. So I think, again, it's careful patient selection based on biology and anatomy, but it is a good evolving option.
And are you using more and more chemotherapy in addition as a kind of a downstaging approach?
We are using sometimes capecitabine in combination. There is some data for that. There is data for gemcitabine plus cisplatin from Julian Edeling and group, but it is a very small study. And so I think we're also a little worried about toxicity in combination, though in a small series that it looked feasible.
Yeah. Okay, many thanks. And Juan, you want to comment here?
Yeah, I was just going to make one comment, and something I learned through my clinical practice is that, you know, patients who are deemed to be unresectable are sometimes on a palliative pathway in that they have whatever treatment it is, whether it's systemic treatment or local regional treatment, and maybe having a minor response and a further minor response and a further minor response on the scan after. And I think what's really important is that these cases are rediscussed at multidisciplinary teams so that we don't miss the patients who do have a good response to treatment and are rendered resectable, even if initially they were deemed unresectable. And I think this speaks to this multidisciplinarity, not just at the initial assessment, but all the way through the treatment course.
Yeah. No, I think this is so important because quite often we still have the feeling that, let's say, outside of specialized centers, if the diagnosis is cholangio, then people think we can't do so much, you know, regardless what we are doing, it will not really change the life or the life expectancy. And I think this clearly has changed, right? We have so many options. And Katie, you want to give a brief comment on that?
I was just going to draw a parallel to HCC, as you had asked about before, which is, to Juan's point, doing a series of therapies and watching a patient's response over time, or at least a couple of cycles, either whether it's systemic therapy or local regional therapy, and then reevaluating is really what we do in HCC for patients on the transplant list or patients getting local regional therapy for months to years. We learn their biology that way. And I think that often big decisions in cholangiocarcinoma might be well served by doing the same.
Yeah. Daniela, we will come in a couple of minutes again to the biology, but first, I think we need to discuss quite briefly systemic treatment. And systemic treatment has changed a lot. First line, second line, new treatment option. And of course, the big innovation was the introduction of immune checkpoint inhibition with the current standard of DOVA, GEM-CIS, a standard treatment for the advanced disease that needs systemic treatment. This was a TOPAZ trial with a 12.8 months survival as compared to 11.5. This doesn't sound a big difference, but for certain patients, it could make a big difference. But now KTU published a similar study where DOVA was replaced by pembrolizumab, a PD-L1 immune checkpoint inhibitor, whereas DOVA is a PD-1. But the results as first-line treatment in this was quite similar. So do you see any, well, is it interchangeable or is it both good? How should we deal with now two quite similar first-line treatments?
Yes, so I think a couple points to make. First, immune checkpoint inhibitors by themselves have minimal efficacy in cholangiocarcinoma, except for the 2 to 3% with microsatellite instability or mismatch repair deficiency, who we should always be looking out for with family history and molecular profiling because it can be sporadic. But absent those 2 to 3%, by themselves, the immune checkpoint inhibitors don't help much. And I agree with you, the improvement in the median survival in TOPAZ-1, as well as the pembrolizumab study that I had the honor of being part of, the Keynote 966 trial, the median improvement was modest. It was clinically significant and statistically significant, but not nearly what we'd like. As a clinician, though, what I see is meaningful is the tail of the curve in both studies, and they're a little different, and I'll explain why in one moment, but both of them show that the effect is durable. We're not just seeing an improvement in the median that then collapses and coalesces with the control arm by 24 months. We're seeing it sustained. What that tells us is that our hypothesis that the combining chemo makes tumors more immunogenic because of MHC expression and tumor antigen expression, or all the potential ways that it could happen, is potentially creating a group of people whose immune systems are now kicking in and helping recognize that tumor for the long run. And so it's that subset of patients in TOPAZ-1, it was about 25% at 2 years compared to 10% in the control arm that were still alive. In Keynote 966, that difference was a little smaller, but also hit 25% in the treatment arm. So we're seeing this durability and a flattening out where there's a subset of patients are getting prolonged benefit. The two studies are slightly different in their tails because the Keynote trial allowed for continuation of gemcitabine that whole time. And so it's an active control arm, whereas Topaz stopped the treatment. It was an inactive control arm. So we see a little bit less
And is there any
differential.
preference in your view for one over the other, or do you think we
they're
can use
interchangeable.
both?
I think they're completely interchangeable from my perspective.
And there was now also recently, I think we have to briefly discuss it, the IMbrave study, where they studied GEM-CIS plus atezolizumab, and then as a control group or as a more, whether to add bevacizumab. And what do you think? Progression-free survival, I think, was here the primary endpoint. But there was not a big difference between these two arms. But do you think also we can now use GEM-CIS atezo as like we do with DOVA and Pembro?
Yeah, so what we're seeing here is that the impact of checkpoint inhibitors, as Katie has said, is fairly consistent across the studies. I'm sorry, can you hear me?
Yep.
Yes.
The primary endpoint here was median progression-free survival, and there was the question around this study wasn't really about the atezolizumab, because all patients in the study, for those of you who are not familiar, is a randomized phase 2 study. All patients receive cisplatin gemcitabine atezolizumab. And then the difference is whether bevacizumab or placebo was the difference. So it's whether bevacizumab added something more. Bevacizumab did add a little in terms of the median progression-free survival, but there was no difference in overall survival, response rate, and disease control rate. So For unselected all comers, probably not the right way to go. But the study presenters did highlight that there may be some subgroups of patients who might benefit from the addition of bevacizumab, maybe with high VEGF-A levels or some other markers like PI3 kinase and AKT mutations. But right now, the key message is you could use atezolizumab based on that study. Whether you add bevacizumab or not, probably not in unselected population.
Yeah, and of course it's not licensed yet, so we have to see. So before coming to second line treatment, and again the molecular profiling and the importance about this, there's one study, and I think Juan, you also co-authored, published in Hepatology from Adeline, combining TAR third with systemic chemotherapy with a very impressive median survival of nearly 22 months. So just a very brief comment. Do you think this is really something we should more often consider doing, these local regional plus systemic treatment? We discussed it briefly for downstaging, but is this also something when we perhaps a secondary resection is not very likely, but still to reduce liver burden or burden of the disease and within the liver, that can be prognostic quite important.
So Professor Julien Edelin and the group in France had very good results on a phase 2 study called the MISFEC study, which was using cisplatin gemcitabine chemotherapy with the introduction of radioembolization during the course of treatment. So after the first cycle of chemotherapy. Their response rates were close to 40% with a very high disease control rate of 98%. And the median overall survival was impressive at 22 months. The problem is that it was a single arm study and there was no context to be able to interpret those data. So what we did in this study was we did a post hoc analysis of prospectively controlled data that was collected in ABC studies, America studies, the Bingo study. So all of these are patients who had received cisplatin gemcitabine or gemcitabine oxaliplatin. And then there was a process of propensity score matching. And once that was undertaken, it was able to provide a bit of context. So those patients who had chemotherapy alone, for example, had a median overall survival of 15.9 months, so let's say 16 months, but with radioembolization, 21.7 months. So there did seem to be a difference. But even with the best matching, this is not a randomized control prospective study. There was such a study that was running, but unfortunately was closed early due to lack of recruitment. But I think we still need that level 1 data to be able to use this.
But it really shows you all, how the field is quite rapidly moving, and what we mentioned in the beginning, that also local regional therapies perhaps more often will be used in managing these patients. But now we need really to come to second line treatment option, what to do if patients or if the tumor progress under the first line treatment. And I think all guidelines do recommend that we then need a molecular profiling. The EASL guideline is mentioning if from the beginning it's quite clear that you will not have a cure also on lymph node positivity, go directly for profiling. ESMO guideline telling from the beginning. So Daniela, what is your thought about when we should do it, how we should do it? What is the role of liquid biopsy?
As many as possible, that will be my answer, but I know the challenges of getting biopsies. We mentioned already first line treatment. Of course, there is a need in second line because we know that we have FGFR inhibitors and IDH, so we need molecular profile at that level, but it wouldn't hurt to actually biopsy the tumor even before GemCis plus PD-1 or plus PD-L1, because we need to understand who are the patients who can respond. And we cannot do that otherwise. So I think that access to biopsies is mandatory, or at least I think it has been recommended, right? If the tumor is not resectable. But I will recommend, ideally, I will have a biopsy as soon as the patient is diagnosed with an advanced non-resectable disease. And that will already be informative and identify biomarkers for first-line therapy. And of course, identifying if there are alterations that can be targeted. And I think it's important because we are employing this here at Mount Sinai, but this has been a struggle to actually require molecular profiling. I would like to know where we stand at the other centers.
Yeah, and how long it normally takes to get your molecular profile and how you're doing it, because I know that sometimes you can miss, depending on the methodology, important treatable, druggable targets.
Well, here in the US, we use also foundation medicine, particularly Sinai also has a couple of pathological assays that allow, through pathology. We do this through pathology. It takes a couple of weeks, and I will definitely recommend to have both DNA and RNA sequencing, because when it comes to fusions, unfortunately, if you only do DNA sequencing, since the breakpoint occurs in the intron on the FGFR2, we're going to miss the FGFR2 fusions. They're not going to be easily identified by DNA sequencing. And you mentioned liquid biopsies, and while liquid biopsies right now is great to identify mutations, there are challenges to identify FGFR2 fusions. So again, the access to tissue is necessary, and application of both DNA and RNA sequencing. This is what we try to do, at least panels that combine and allow to identify both.
Yeah, and Katie and Juan, I think in your centers, you're both doing it from the beginning, right? And with full sequencing and NGS and
yeah,
testing.
For any advanced cholangiocarcinoma getting systemic therapy, we order tumor molecular profiling at the time of advanced diagnosis, because we don't know who's going to be a primary progressor and need those results quickly. I also make a case for ordering it in patients that are super high risk, like positive lymph nodes after surgery, because the risk of recurrence is so very high, clearly in excess of 70+% chance of recurrence.
Yeah, just to quickly add to both comments. You heard that we need to get DNA, we need to get RNA, and increasingly now we also need to look at immunohistochemistry for HER2 expression. So as we get a better understanding of new targets and new therapies coming along the line, there's going to be more and more demand to get this tissue assessed as quickly as possible in different panels.
Yeah, I think this is really so important, and we really have to educate and the centers really to store these samples. Daniela, if you have found a druggable target in your initial biopsy, then the patient is on systemic treatment and you progress, how important it is to get another biopsy then in order to see whether still this druggable variant is present, or whether new variants emerged, or new druggable targets and mutations emerged.
Yeah, on-treatment biopsy is very important as well. I think Katie mentioned it before, right? We have seen it with FGFR inhibitors, that they're the acquisition of mutations that confer resistance that are easily detected, and I would say easily, right, with liquid biopsies. But again, there could be other alterations that we don't even know right now, right? So I think that there is a great benefit on continuing biopsies on treatment, even more when it comes to immunotherapy, right? Response to immunotherapy is dynamic. So if we want to also understand that, I think it's important to do before treatment and on treatment.
Yeah, and depending on the variants, on the profiles, we have now, I think, 5 or even more different treatment options, right, Juan, Katie? So it really is important and means something for the patient.
Yeah, and I think some of these groups. Sorry, go ahead, Katie.
No, you go ahead, Juan. Go ahead.
Some of these groups might be quite small in terms of percentages, but when you add them all up, then in fact, what's important here is that we're able to identify a targetable alteration for which there may be a treatment for a patient. But we also need to be mindful that even when we start these treatments, we need to try and understand how patients develop resistance, or how the tumors become resistant. So as Daniela said, some of that longitudinal sampling will help us to understand that.
So I think, unfortunately, we have to come to an end, but I would like to give you the chance really to, well, perhaps your personal summary of this session and what you want to say. So perhaps Katie first. And
I guess I would just say that it is so exciting and more optimistic than ever before in my career to be taking care of patients with biliary tract cancers. It's still a very difficult and often sad disease, but there are so many glimmers of hope in so many different aspects of the care, whether it's early stage with more surgical and local regional options to more advanced stage with more biologic understanding of the tumor and actual targeted therapies, that we have much more hope than we've ever had before, and progress on the horizon, I think.
Thanks a lot. Daniela.
I think that I can echo what Kelley said. It's very exciting right now. I think that there is a lot to be done I have so many questions. I think that we need to put more effort in understanding the biology, immune responses, and that will guide. Definitely, this is not a tumor for all comers. I think that we need to identify subtypes, see their molecular profile or even immune responses. Patients that might have certain immune microenvironment and certain capacity to respond to certain treatment, not other. And I think this is the perfect cancer for personalized treatment. We just need to push it forward.
Excellent. And I think this has become quite clear in our discussion. So over to you, Juan.
Yeah, that was my takeaway also. I think biliary tract cancer has become the poster child for personalized medicine. It's a very exciting time with understanding the biology better, having new treatment. But a sobering thought is that we've made very little to change the 5-year survival of these patients, even with some of the exciting new treatments that we've had. So it remains an area of unmet need. It's important to identify these patients and be involved in clinical research, encouraging patients to take part in clinical trials so that we can keep on advancing the field.
Yeah, so it's really my pleasure to thank you all for an outstanding discussion. I enjoyed the session very much, and I do hope the audience enjoyed it as well. So it's now my pleasure to introduce you to the next EASL Studio episode next week, where speakers will address of whether the traditional term of cirrhosis is outdated. That's a very provocative title. I think it would be interesting. So I would like to say goodbye, and please remember to become part of the EASL family and become a member, and wish you all a good day. Bye-bye.
Thank you, Thomas.
Thanks.
Bye-bye.